Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps.
All
Hey,
right, Nick.
Jan. Hey, how's it going?
Good, Nick. Glad we can make this work tonight.
Yep. It's been, busy summer and we've kind of put a pause on our live episodes, but it's still there's a lot of trauma going on and a lot of vacations, but we thought we'd jump on a call and talk through some cases that we've run across on orthobullets and other cases that have been presented. So it's good to see you again, and hopefully we'll get going up again here in the fall.
No, absolutely. Yeah, thanks for the invite and organizing this. And yeah, we'll go over a few cases. Maybe we can start with one of these questions that seems to be pretty popular, is an emergency type question for us orthopedic and podiatry surgeons as well.
Yeah, I think there's a lot of new faces that we're seeing in our residency fellowships this time of year. So it's always good to talk through the foot and ankle emergencies that we can sometimes see. So this is a popular question that gets asked quite a bit. And there's foot and ankle emergencies, I guess, but and even there's you might argue that there's less and less orthopedic surgeries that get you up in the middle of the night. Certainly does happen with really bad injuries, polytrauma. But let's talk through some of the foot and ankle stuff. In this particular case, that where there's emergent, urgency to this case. So they like to ask about this on the boards, and I think it's a good one to discuss.
Yeah, so I'll start out with the question stem. So this is a 34-year-old male prisoner decides to jump from the top floor of the jail and falls about 20 feet. So we're ready thinking that's a pretty high energy injury right there. Lands on his feet, immediately screams in pain, unable to ambulate, and complains of significant pain in his left foot. He's taken to the emergency department by the officers, where the radiographs are obtained as seen in figure A. So here, I'll click on figure A. Yeah, so Nick, what do you see here?
Well, it's a single lateral view, and but I think it's enough. We always talk about one view is no view, but this view should at least get you out of bed and to the emergency room immediately. And what you're seeing is a fracture of the calcaneus with, I would call this, I guess it's a kind of halfway between probably an avulsion, tongue type of fracture. I think that's a good point of discussion of how do you classify this, but you can see that obviously the Achilles tendon attaches at that insertion and has avulsed that posterior tuberosity of the calcaneus dorsally and posteriorly. And the reason we get so concerned about this particular injury is because it really puts a lot of pressure on the skin. And that if you feel on yourself or you see any patients, you know how thin and tenuous that skin is. So you get that dorsal displacement, posterior displacement due to the fact of the Achilles kind of avulsing that piece off. And that gets to be a really big area of concern when it comes to calcaneus fractures.
Yeah, absolutely, Nick. And I think, if you can kind of help explain to me what you mean by like the avulsion fracture versus the tongue type, because for me, I classify this as it's getting me out of bed type of fracture, and I need to fix it. What are you when you're saying
yeah, I think I'd call this an avulsion because of the mechanism, right? I think in this case, like the mechanism of an avulsion is the Achilles tendon pulling this off. Now, a tongue type occurs where the fracture goes into the joint, but I think of that as being more of axial load of the talus into the posterior facet and creating kind of that fracture line out the back. Now, you maybe correct me if I'm wrong. You're a lot more trauma heavy than I am, but that's kind of how I think about them differently. Now, they can both get you out of bed because if you have a tongue type that gets posteriorly displaced and threatens the skin, it doesn't matter what the mechanism is. You still got to get there and manage it in an emergent fashion. But I think that's how I think of these as being a little bit different. What do you think?
Yeah, no, I'm with you on that. I think it's more the mechanism and where if it goes into the joint or not. Either way, though, I think it's a lot of it. I know some people are very passionate about it. For me, it's just, I'm still looking at this as a threat to the skin.
Correct.
And so, yeah, we can talk about it if it's an avulsion versus tongue type, but, and I think that, like, obviously, I think, tells you like about the joint involvement. But here I'm worried about skin necrosis, right? And no matter what. So this, so at 11 p.m., Nick, your resident calls you with this. What are you doing at 11 p.m.? Are you boarding this you got a trauma room the next morning? Okay. So what are you doing?
Well, I think there's a couple factors. One is it depends on the patient health. A lot of these occur, like this person's obviously young, so you assume he's a little healthier patient, but it seems like a lot of these occur in a little more frail skin, diabetic, osteoporosis kind of situation. So you're already kind of behind the eight ball. So that's one thing. We actually just talked about this at conference this morning that, some of us will have them take a video, like a very detailed, careful video of what the posterior skin looks like and if it blanches or not, for that kind of question. It needs to go to the OR very quickly. And the question if it goes that night or if it goes that next morning, I think is dependent on, what the health of that skin looks like. So if you get a good view of it and you have a good detailed exam, then you can see that skin is blanching and it's not white, it's not threatened. Then I think you can put them into a plantar flex splint with a ton of padding and take them that next day. Especially in this guy is younger and healthier, assuming. Now, if they're diabetic and they have other risk factors and the skin isn't blanching, that's one I think you come in the middle of the night and you just manage it then. Because if it starts to be an issue, it's going to be so much more difficult to manage a non-healing wound in that area. And if there's I think at the end of the day, if there's any question or if you have any questions about it, you take it that night.
Yeah, I'm with you on that. I tend to be pretty aggressive with these and just take them the same day or right away.
Yeah.
And I think just at our institution, we don't know what's coming in next.
Yep.
So if there's an open fracture I need to take in, I don't want to delay this first case in the morning.
Yep.
But you're right. I think, I've sometimes seen these where the skin looks fine, or they've presented to my clinic 2 to 3 weeks later, and amazingly, the skin looks okay. And I've also seen the opposite where they present to my clinic 24 hours later because they were just read as a calcaneus fracture.
Yep.
And they have basically dead skin. So
Yep.
you got to have these, you got to be on the lookout for these and treat them accordingly.
One of the more interesting cases of these that I saw was a physical therapy assistant who came in and he had a history, young, healthy guy, history of an Achilles rupture on the contralateral limb a couple of years before. So he falls off of a step, feels a pop, goes into the emergency room. Thompson test is positive and didn't get an x-ray and ended up showing up with almost that exact fracture like that. And so it was just and the kid thought, he's like, oh, I tore my Achilles again. He didn't kind of give it a second thought. ER examined him. Yep. Thompson test and didn't get an x-ray. And so this is one of the reasons I always advocate for getting an x-ray in Achilles. It's usually not that dramatic, but sometimes it's just an avulsion, sometimes just insertional disease, but it can be helpful and it can save your butt for sure.
Absolutely. So looking at these answer choices. All right. So we have to OIT in just in a few months, but we got new residents who started here. Anesthesiologist on call asked why the case cannot be delayed until the following day. I love how they blame the anesthesiologist even in the question, right?
Yep.
What is the reason for surgical urgency in this particular case? So, Nick, what would you answer here for this patient?
I think we kind of mentioned it already, but the biggest concern you have is the issues with soft tissue necrosis. And so that's going to be your answer in this particular case. But it does sometimes come to that this is something that it's important enough that if you're concerned about it, it's not something you're like, yeah, I can wait for that lap chole or something. This should actually level and be getting into OR pretty quickly. So I think that's a good point to make.
And I'm really happy that it says right here that we have 96% of people got this correct. I think that's awesome, right? That's you hope it's only almost going to be 100%, but I would take 96% right now. So I think that was
Can we talk through a little bit about the like how you're fixing these, Jan? I'm curious.
Absolutely.
Like first off, like your position. So you call the OR. I mean, what do you think of position? Do you do these lateral? Do you do them prone? Do you do them supine?
So it depends. So if the patient is otherwise healthy and they're not like part of polytrauma, so they don't have like other injuries, I usually will go prone. For me, I think that's just easier to reduce. But if they have any other contraindication, they got rib fractures or they're unhealthy or obese, I will go lateral. So lateral or prone for me, I think either way, I think either way, this can be fixed fairly well.
And
What
then,
about yourself?
yeah, same. I prefer prone. And lateral in a pinch, I guess, if you need to. I think another question that came up is when we were talking about these before is role of a gastroc recession. Is that something that you're frequently incorporating? Is it something, and then maybe talk about like your sequence of events. Do you do it after you get your reduction when you're at risk of maybe, as you dorsiflex the ankle, of displacing your fracture fixation, or is it something you're kind of doing when you have provisional reduction? Like how are you incorporating it? How are you even assessing it? Because it's gonna be, you don't want to stress it that much if once you fix it to test for Aquinas.
Yeah, so I don't want to say always doing it, but I'm very often doing it right off the bat. So I don't want to test it because you have to test it when it's fixed. So I just go ahead and do it right away, and it only takes a couple of minutes, and then go ahead and fix the fracture. I've not been, knock on wood, burned by that approach yet. I think many times, especially if this is an avulsion fracture, it's from the Achilles being too tight anyway. So you're kind of helping with that pathology from the beginning. And I think the downside is low for doing a strayer on these types of patients.
Yeah, I would agree. I think that it's something that it's going to protect you. These can be hard to get to heal. The bone quality in that area is not often that great. So fixation can be a little bit tenuous on these. And so I think anything you can do to try to take whatever stress off that area, I think is really important. And then you're calling the OR. What are you asking for? Or maybe let's go back to approach. How are you trying to get these perk and then put screws in, or do you open them at all? I mean, obviously you probably try to minimize the opening, but curious how you manage that.
Yes. So when I'm calling the OR, like some of the things that I'll have ready to go are cannulated screws.
What size?
Yeah. So I go back and forth with this. I use a minimum, usually like a 5.0, but I've even used 6.5 cannulated screws as well. It really depends on the patient's bone quality.
Yeah.
I've noticed that some patients have poor bone quality, like an older, more geriatric patient. I need to use a bigger screw. And so I've used that even with a washer, and because like you said, these can be difficult to fix. Like conceptually, it's easy.
Yeah.
Let's put, clamp and put a screw, but there's quite a bit of force on your fixation, and especially if the bone quality is bad. So I'm asking for that. And then in terms of my approach, many times I'll put a Chance pin in the heel and just lever that. And then
So you put that in the displaced fragment and then use that to pull down, or you put that.
Yes. Can you see the X-ray here?
Yes.
So I will put the Chance pin right here.
Oh, I see what you're saying. Okay. Yep.
And then I lever it. And then I'm using a Weber clamp.
Yep.
That's holding it down then and clamping the heel. And, so like that. Sorry, my Weber clamp's not a great. But it's clamping that together. And so
it's like our actual clamps, actually. It's probably better than the actual ones we have.
Yeah, it designed just for this. So Paragon should buy it from us.
There you go. That's right. Well, I'll mock up an idea.
But yeah, so I use a Chance pin in that tuberosity fragment, mobilize it. Usually I can mobilize it without making any other additional incisions. Sometimes you have to put some type of elevator in the fracture just to kind of flip it, if it, just kind of free it up. I usually don't need to do that, but I have done it in the past, and it doesn't take that much force. You mobilize it, and then the clamp is going to help you. And then I will fire across a few cannulated screws like that.
Yep.
Across the heel.
Yeah. I like how you kind of start a little more closer to the joint. I mean, I'm assuming that's the sequence that you put in, start a little closer to the joint. I like the idea of having, or at least starting with like a 5.0, 4.5, 5.0 screw, is a good starting point. That leaves you a bailout if you need to go to a bigger screw for additional purchase, so you don't like kind of, you know, burn bridges with it. And then I think also one other thing that I've done occasionally is if I'm concerned about it, and this would be more if you're doing something open, for example, like it's presents in a more delayed fashion, is occasionally I'll take like a play out of the knee playbook when it comes to like a patellar tendon rupture, put sutures into the Achilles, and then pass them through the screws and try to tie them, you know, kind of on the plantar side of the foot. It probably ends up on the plantar fascia by the time you're done with that, but it just reinforces it because a lot of times the bone quality is wispy. I've seen too, as I was kind of, you know, prepping our residents for some of these things, was talking about putting like a rim plate almost, you know, like the patella, which makes me a little bit nervous, you know, kind of wrapping over the top. There's a case description, I think maybe out of JBJS or somewhere. And they talked about using that kind of technique to kind of stabilize it. And then I think mentioning the size of the fragment, you know, so if it's a pretty small piece, you maybe don't need to be thinking about fixing that. You can excise it, you know, and maybe drill holes or whatever fixation you want to repair the tendon back down to the bone. So, but those are all really good tips, I think, to keep in mind as you're prepping for this kind of case.
And the other thing I would say is if you're going to use screws, which most of the time I do, I have sometimes even, like you said, through drill holes. I've used an acute like suture anchors, you know, excised it and then just done a primary repair of the Achilles. But you need to be bicortical here with your screws.
Yeah.
You know, even if they have to stick out a little bit, I mean, you might have to take them out later on. Like you said, it could be irritating to the patient. But if you're dealing with that, that's a win.
Yeah.
In my
For sure. That's the biggest problem. We'll take that. The other thing to mention is I think headed screws in this case is going to be better than a headless. I like headless screws. I don't want to give that impression, but I think a headed screw here is going to be probably a better option because then you have the bailout to put a washer to get a little bit more purchase on that piece.
Absolutely.
Well, that's a good one. I mean, not good for, you know what I mean? It's a good discussion case to talk through and hopefully it's helpful.